not have enough of the thyroid hormone in their body, right? And so I'm needing to increase the amount of thyroid hormone that they have, so we have our medications that we make to be able to do that, okay? So what was our drug of choice that we said that we like to use to get them back to euthyroid? Levothyroxine or our Synthroid, right? So making sure that you're remembering your drug of choice. Those one-offs that I have put on top of that, or on that chart, where you're watching out for your desiccated thyroid, those are the two big things that are on there in your one-offs that you can kind of see. Making sure that you're understanding that we are looking at and targeting different levels of the T4 or the T3 depending on what your patient's labs look like, okay? You're going to pull those labs and then you'll know which one you're picking. For me, I just need you to know that they exist, that they are all options that you can use to treat a patient who has hypothyroidism, and what is your drug of choice, okay? We'll talk about some more indications of when you can use them in a minute. So, if I have hypothyroidism and I'm taking a medication to try to replace what my body is not making, and I overshoot that, my adverse effect is that now I can have them have symptoms of someone who has hyperthyroidism, okay? So I overcorrected. I gave them too much, and now they're going to appear as someone who has hyperthyroidism, and we'll talk about all of those side effects when you see the picture. But essentially, it's like you're speeding everything up. Think about like a hyper person, and they're all over the place. So you have weight loss, their cardiac function is all over the place because their heart rate is a little bit faster. Their BMD can go down, and it, again, remember, this controls a lot. It was controlling my metabolism. And so when you see this, especially when you see it in kids, we have a lot of growth issues that may happen with them. So your adverse effects of giving one of my medications for hypothyroidism is that I overshoot my mark and I give them hyperthyroidism. What do you think I do to fix that? Do I stop it or do I reduce it? Reduce it, right? And I find what the sweet spot is for that patient, okay? So if I overshoot, and that's why we're trying to titrate them, right? We're trying to figure out what works for that patient. This is the hard part. Once you get them on that dose, they're usually good for a very long time, unless like something changes in their life, disease state. You can have some disease states or conditions like pregnancy, where then their thyroid, their dose of medication will change, okay? So that is what you're trying to do. If your patient comes back and they're still telling you that they have the symptoms of the hypo, right, too slow, everything slowed down, then that means you need to increase your dose. If they come back and now they're like, hey doc, my heart feels like it's racing, like I'm all over the place, I'm losing weight, and you get their weight and you're like, some people might be like, I'm losing weight, like that's great, right? But this is not great in this situation because I have overshot. So if I see them come back and they're telling me they're having these hyperthyroidism symptoms, then I'm going to decrease my dose. Okay, so understand what you're doing with your Synthroid. My interactions, I have a lot of interactions when I'm talking about our Synthroid medication. So when you're looking at this, just make sure that you're looking at the ones that are going to be in bold. So again, whenever you're talking about iron acids, anytime we look at iron acids, we can have where they can interfere with the absorption of some of our medications. There are very few where this doesn't matter. And then you see your acid reducers, so like your proton pump inhibitor or your H2RAs. If I need an acidic environment and you're now suppressing that, right, and you're controlling that, then I may have issues with absorption, okay? So your absorption will essentially decrease in that situation. Your clearance increased via induction, right? So these are some of our anti-what medications? We have some anticonvulsants in here. I have my rifampin. What is rifampin? Is it a TB antibiotic medication, right, that we have? So when we're looking at these, understand that these can cause induction. And remember when we talked about these last semester, these were the ones that interacted with everything. Right? These were those drugs where I said, if you ever see them, you put them in because I'm sure that something is going to come back and hit and say that it interacts with one of these meds. So thinking about this with our thyroid medication, same thing, interacts with that. When we talk about some of these other things, your estrogens, amiodarone, propranolol, lithium, and then again, we'll see warfarin continue to pop up in the next couple of lectures sometimes when we're talking about some of our meds. So make sure that you're looking over our drug interactions that we have that are listed here. Sorry, y'all, I'm trying to push through. If we finish, I might finish early if I can continue down this road. We'll see. This is a summary chart giving you all of the different types of thyroid replacement options that we have for our patients, right? So hypo is low, right? I need to replace it. I love to use my levothyroxine, which is my Synthroid that I have, and you see all of these different strengths because there's a sweet spot, and you have to find that for your patient, okay? There is, once you start practicing, you'll be like, well, typically my patient can take this. But if they come back and they're telling you like, hey, my symptoms are like, I can't handle it, then you know, okay, I need to back off, right? Because now they're in that hyperthyroidism state. So I want you to pay attention to the drugs that you have available. So your desiccated thyroid, that was the one that we were watching out for. What's in there? Pig, the pork, right? Then you have your levothyroxine, that's my drug of choice, the one that I love to use. Your liothyronine and your Leotrix are just other options that we have available. Pay attention to your comments, okay? So when you're looking at your comments, again, because of that animal source, your body is likely to respond to it. So you can see those hypersensitivity reactions, watching out for your patients who have religious reasons as to why they don't want to have pork. And because it does come from that thyroid, we may be hit or miss on that dose. So it's not very effective sometimes when we're talking about controlling someone's hypothyroidism. So that's why we also don't love this, but you have some patients who will say they want to be on the stinky med. Okay, this is the stinky one. Then your drug of choice, make sure that you remember how I told you, you want to make sure that you have left their stomach empty. So this one is an empty stomach. Before they have anything, typically we'll tell people to take this one in the morning because some of our patients would complain that it was kind of activating to them, okay? And then looking at your liothyronine, you see that this one is the one that has a great risk for the cardiotoxicity. So if your patient does come back after you put them on this and they're complaining of that tachycardia, you also need to make sure that you're doing a full workup, right? To make sure what's going on, and if they're on this medication, you could see that cardiotoxicity occur, so don't just blow your patient off and think that it's just a simple dose thing sometimes. And then looking at your use for this. So you see what's different about this one is this one has more of your T3. And remember when we talked about at the very beginning our conversion, and we had that peripheral conversion of our T4 going into our T3. So if I can't convert my T4 into T3, I can now just give them that T3 if they came back with low T3 levels whenever I pull my labs. So I can potentially have perfectly fine levels of my T4, but I'm not able to convert it to the T3, okay? So this is this medication that you can use in those patients. I haven't seen this used a lot, but we do still see it used, okay? So this will be driven by your labs that you have and your patient is coming back and they cannot do that conversion, so they have low levels of their T3. And then your Leotrix, remember this is the one that was trying to trick your body, right? It's trying to mimic that natural proportion that we have between our T3 and our T4. The only other thing that I wanted you to look at was this levothyroxine, this bolded for the dose. All your other ones are not worried about the dose. We already talked about our titration. But when you're looking at this, I want you to understand that if somebody is over the age of 65, or if they have any cardiac disease as it is before they're taking any of these meds, then we want to start them with a 25 microgram dose and then slowly titrate them up, okay? You do have this weight-based option that we're doing when we're talking about this medication, and sometimes it works and sometimes it doesn't. So that's where your clinical judgment is going to come into play on whether you're titrating them up or down based off of if they're having those same hypothyroidism effects or if they're having the hyperthyroidism effects. That means you overshot and then you can go down, okay? So that their weight is your starting point. And then you'll start to titrate them from there unless they are over 65, or if they have any underlying cardiac issues, then you're starting at the 25. Okay, so that's all I need you to remember for the dose. I don't need you to remember the about 1.6. I don't need you to remember that. I just need you to remember the cardiac and the age, and that you're starting at 25 in those situations. Okay. Myxedema coma. So this is something that is essentially happening due to the thyroidism, and it is a medical emergency in your patients. They can lead to loss of brain function, which could ultimately lead to death if you don't catch it. So when you think about this, remember again, hypothyroidism, everything is slow, and this is the big condition that we have that is a medical emergency for those patients with hypothyroidism. So when you have myxedema coma, all I want you to know is what you're using to treat it. We said this is very severe hypothyroidism. I told you my drug of choice for hypothyroidism was what? Levothyroxine. But because this is an emergency, now the only thing that has changed is I'm giving this to them IV. I need to hurry up and fix this issue, okay? And then you see that I can give them the hydrocortisone because I'm trying to make sure that there isn't any adrenal suppression that's also happening. You have to rule that out in those patients. So when you're thinking about this, just make sure that you are understanding that this is not an oral option of our levothyroxine. This is our IV option that we're giving our patients. They're going to be admitted into the hospital for you to take care of them, and we're trying to replace that deficiency that they have. Okay, so IV levothyroxine, and then you're going to do your hydrocortisone in those patients. Okay, so complete opposite of what we were talking about with our hypo is what you're going to see whenever you're looking at your hyperthyroidism. So think about it as being activating. Again, think about that person who's like running around all over the place. So now I have too much. My body has produced too much thyroid hormone. And then our big thing that we're going to talk about here, we just talked about the myxedema coma. Here we're going to be talking about a thyroid storm and how we're going to try to fix that. So just make sure that you're understanding the big disease states that you're looking at when you're dealing with both of them, because then it can kind of help you with understanding which medications you're using in both of those emergency situations. Okay? So in my hypothyroidism, I had what? Coma? Myxedema coma. And what did I use to treat it? IV levothyroxine, and then I can give them that steroid with it as well until I rule out the adrenal suppression. So when you talk about thyrotoxic crisis or thyrotoxicosis, this is, again, I have very, very high amounts of that thyroid hormone that's being produced, and then it can lead to the thyroid storm, which is, again, what can be life-threatening for our patients. So we're going to talk about how we deal with our patients who have hyperthyroidism, and then our patients who present and they are in a thyroid storm. How do we help those patients? When we look at some of the disorders that could lead to us having hyperthyroidism, we have different types of goiters, right? So when we were talking about, remember we saw the guy with the non-toxic goiter and he had the salt picture? That was a non-toxic goiter. This one is a toxic goiter that they have. And the disease that we like to talk about here is going to be Graves' disease, okay? Autoimmune disease that's occurring in our patients, and just understand that we're trying to now slow down what their body is doing, right? Now they have way too much hormone, body can't handle it, and so everything is in overdrive. Everything is now activated, okay? We also have where we can have drugs that do this. So one of our drugs that does this is going to be amiodarone. We can have some of our medications where it's like, hey, I can cause, right, too much of that thyroid. Oh yeah, by the way, that question is coming back. I told y'all. I also, somebody came to ask me about this. Thank you. Thank you. I also, we did the testing committee, and I think your stuff is supposed to be up by today. I submitted everything, well, they submitted everything already yesterday, but I don't know if your grades are gonna be reflecting of that today or tomorrow, but it is in. I can't remember the other ones because we were in there for a long time, and I was getting real frustrated. But there are, I think, at least 2 or 3 questions that are going back, if I can remember correctly. But I think it's 2. And I think the other one was the pain one, with the fentanyl and the Percocet. When you're looking at that, make sure that future reference because I think you did dual. You had to have picked an opioid. If you did not pick an opioid, y'all just wanted that poor lady to suffer. But on that one, if you picked the opioid, I think that we ended up doing dual for that. But the idea for that one was she had been in remission for 3 years. She wasn't on any pain meds, so she was considered opioid naive. So you would want to do the Percocet versus giving her the fentanyl patch. She could potentially progress to that if the Percocet wasn't working. That was the idea behind it. I sympathized whenever I saw it, and I was like, I tried to clean it up, and clearly it wasn't enough. So I think that one we did dual. Y'all will see when it comes back. Okay, so that's this. So our drug induced. And then you have your thyroiditis, which could also occur. You're going to learn a lot more about all of the different things that can happen, because sometimes you have even adenomas that could potentially also be secreting some of that thyroid hormone as well. Okay, so just understand that there's several reasons as to why I could have hyperthyroidism whenever I'm looking at my patients. So again, I told you they're activated, right? So everything has been sped up, everything is activated. So when you look at this little poor man or woman, I can't tell, intolerance to heat, right? So when I said hypothyroidism, it was intolerance to cold, right? And I could have started to see my weight fluctuate. We also see the same thing happen here. One of the big things that we notice is people's eyes, right? They'll have those bulging eyes whenever they have hyperthyroidism. And so these are big things that we look at. Their thyroid could be bulging. They're going to tell you that their heart rate, like they feel like their heart is beating out of their chest sometimes. So this is a very big thing, and the weight loss can be very, very dramatic in some of these patients. This happened to one of my friends, and we were out, and oh my gosh, I can't feel like my chest. It feels like my heart is about to explode. And I was like, okay, you're being really dramatic. And then he stopped talking and was holding his chest, so we were all looking like, oh, he's really serious. So we go to the doctor. By the time we get to the hospital, nothing wrong. Took them like a year before they finally did labs and everything and figured out that hyperthyroidism was the issue. Hair fell out, lost a lot of weight. This is like a 6'6", 220-pound person who was like 170 something pounds by the time they figured out what was going on. So like, labs are important. Look at them, okay? This is what I was talking about with the eyes, right? So you see your ophthalmos that your patients could have, or we also can call it TED, thyroid eye disease. And essentially what happens to this is that their eyes start to bulge outward. Remember, this could be autoimmune disease as to what is happening, especially if they have, Graves. So most of your patients with Graves disease, you will see this happening. Before, we used to not really have any medications that we used for them. We would only have steroids that we would try to give our patient. They would come in, and we would try to treat them in clinic every 3 months to try to see if we could help decrease the amount of thyroid hormone that was causing that bulge to occur. And now we have a drug called Tepezza, or teprotumumab. And what do we see on there? We see MAB again, so our monoclonal antibody. This one, they're going to come and they're going to get their treatment. They'll get it every 3 weeks for 6 months, and then you'll start to see a great improvement in some of these patients. Sometimes after they have that second or third dose, like you'll see sometimes where they have very, very good improvement. So your mechanisms are listed there with how they're working. And again, with this, think about the dryness that somebody can experience in their eyes, right? Because they don't have that same coverage and protection and the lubrication that we would have if that eye was in the orbit. And then your side effects of the medications are also listed there. So when we're talking about our steroids, again, you're going to see them. We're going to talk a lot about them. But those same things that we looked at with steroids before still hold true here. So your blood pressure, your glucose levels, all of those things, your mood. Very quickly, we can also see that insomnia happening. And then when we're looking at our Tepezza, again, you have different issues happening with those glucose levels. Hearing loss can occur. So again, just checking in with our patients. A lot of them, because this is such a, this is cosmetically displeasing to some people, they will probably tolerate and not tell you that they're experiencing side effects, especially once they start to see the benefit of the medication working, okay? So just check in with your patient. If they are breastfeeding or if they are pregnant, they cannot have the Tepezza, they're gonna have to wait. This is just showing you the improvement of this young lady after she had her treatment. And we said that we're doing this every 3 weeks for 6 months. So again, you just see how she was starting here, especially with this eye, and then now it's kind of more symmetrical with her using that Tepezza, okay? So Tepezza is a newer kid on the block. These are our medications that we are using to try to treat that hyperthyroidism that our patient has. So we had 4 that we were mainly looking at when we were talking about our hypothyroidism, and now you have 4 different classes that we're looking at when we're talking about our hyperthyroidism. So when you're seeing the red, that's telling you what the mechanism of action is. So what you're going to do with some of these patients, ultimately, some patients will likely have to end up having surgery because we can't do it chemically with like our medications, okay? We can't ablate that thyroid enough for them to be back at those euthyroid levels. So a lot of them will end up undergoing a procedure to kind of resect some of their thyroid, most of the time, all of it. So your mechanism of action for your thionamides is to block the synthesis of that thyroid hormone. You see your iodides are trying to block the release of the thyroid hormone. Your radioactive isotope, this one is trying to chemically ablate the thyroid, so they're going to swallow that medication and then it goes into the thyroid and it's trying to essentially kill all of that tissue because it's radioactive in the thyroid. It takes a couple of days. Sometimes people are perfectly fine and it works and they're euthyroid, and then other times it may kill some of the thyroid but not all of it, and then they still end up on medication. Or we ablate the thyroid. So if I ablated your thyroid, now what do you think is going to happen to me? I was hyper, now I'm hypo, right? So I'm on a medication no matter what happens to me anyway. Very rarely can I do this and end up in a situation where I'm smooth sailing with my euthyroid. Not likely. Also, when we're trying to use a lot of these medications, we can get them under control sometimes, and then they can have a relapse, right? Where our medications stop working, and then again, they end up in that surgery anyway. When you're looking at your adrenergic blockers, does this look familiar a little bit? Our beta blockers came back again. They do look familiar. All right, so we have our beta blockers, right? This is just the symptoms because I told you hyperthyroidism activating, right? My heart rate is going up. So that's why you can see your beta blockers on here. It's trying to slow everything back down, okay? So these are our different options that we have. When you're looking at this chart, pay attention to your red because this is telling you what it's doing to the thyroid and how we're trying to decrease those levels because hyper activated, I'm up. And then you have your PTU or your propylthiouracil, your methimazole. These are your thionamides. Your iodides, we have different types and we'll talk about when we're using those. Your sodium iodine, that's the one that they're going to swallow. And then it's going to try to ablate that thyroid. Typically they'll end up on levothyroxine after they've had this. And then you have your adrenergic blockers, which is not doing anything. Let me not say they're not doing anything. They have a minimal effect on the thyroid hormone, but mostly what we're doing with this is controlling the symptoms, okay, that patient is having. And most of your patients who have hyperthyroidism will be symptomatic, and so we're going to help control their symptoms with that. I was talking to you about our options to help our patients and how most of them end up in surgery. But a lot of your patients are not going to want to go to surgery right away. They're going to want to try the least invasive thing. So that's where our medications come into play. So these are our 3 different options that we have to fix, okay, my hyperthyroidism. I can have surgery, I can have the radioactive iodine, that was the pill I just told you about swallowing, or I can do my anti-thyroid pharmacotherapy, which were those other medications that we talked about just now, so our thionamides and things like that. So when you're looking at this, just make sure that you understand that when we're trying to chemically fix our issue, sometimes we will still always end back up at 1. So most of your patients will try to start at 3, and then they'll go to 2, and then end up at 1 anyway, okay? This surgery in our pregnant women, we're not going to really want to try to do surgery in our pregnant women, okay? So we sometimes will have some of these meds, and we'll talk about our anti-thyroid pharmacotherapy that we have, where we'll prefer one of our medications over the other in our patients who are pregnant. And then looking at your relapse, you see how high this relapse is for a patient? I may get them to that euthyroid state, but over time, my thyroid is going to do what it does, and I have my thyroid hormone coming back. Okay, so then you can see where I'm going to end up in that iodine category. So I'm going to end up as a 2, or I'm going to end up as a 1 and ultimately have to get the surgery. With the surgery, again, make sure that you're understanding it's invasive, it is a surgery. They will have a small scar sometimes left, and so that's why some people don't like to do that, okay, because they don't want a scar on the neck. Looking at this radioactive iodine, when you're seeing this, make sure that you're understanding that your patient cannot be pregnant when they're doing this, right? Radioactive. This person is also not going to be allowed to be around anyone who is immunocompromised. Because if my immune system is not great, and I go around that person who is immunocompromised, I have now just jeopardized them as well, because I'm now exposing them to those radioactive isotopes that I took when I was trying to get rid of my thyroid. So this also happened to my friend. His mom had cancer, and he tried the anti-thyroid pharmacotherapy, had the relapse, and he didn't want to do the surgery, so he did the radioactive iodine, but then he had to stay in a hotel because his mom was undergoing chemo, and so she was immunosuppressed, so she couldn't be around him. So make sure that you're getting the full family story of everything that's going on, limiting the exposure to the kids, and all of those good things, okay? All right, our thionamides. So when we're looking at this, we have 2 main medications that we're going to be talking about, and that's going to be our methimazole and our propylthiouracil, or our PTU. What this medication is doing is that this is going to try to stop that thyroid peroxidase and block the iodination of our thyroid hormone. So remember, the iodination is when I get to add on those iodine moieties to make my T3 or my T4. So I'm trying to block that from happening. You can also see where you can get a minimal benefit of these medications blocking that conversion peripherally as well. Okay, so there's very few drugs that block that peripheral conversion. When you're talking about your methimazole is usually what we like to use. It's a great medication, and most of your patients tolerate and start with methimazole. In certain situations, like if your person is in that first trimester or their first 16 weeks of pregnancy, or when we're talking about a thyroid storm, you will see that we like to use our PTU instead, okay? So making sure that you understand that your PTU, we like it in our pregnant women. After they get out of that first trimester, you do have where sometimes, or that first 16 weeks, I should say it that way, you do have where we can switch them back to that methimazole, which is the one that we like to use. Some patients may be like, just leave me here for right now, which is also another option that you can have, where we can switch them back. Okay, so your drug of choice, especially when someone is initially pregnant who has hyperthyroidism, is going to be, bless you, your PTU. And then if they are otherwise healthy and there's no contraindications, we like to use our methimazole. Looking at our efficacy, it takes a while for this to work, okay? So you may have to have that beta blocker on board for this patient if they're having symptoms, because they're not going to be euthyroid anytime soon, sometimes up to 2 weeks, or sorry, 2 weeks, 2 months for you to get to that euthyroid state, okay? So understand that they need to take that medication every single day, even though they're not seeing the benefit of it yet, okay? You see the maximal efficacy can be up to 6 months, but we should see some improvement within that first 2 months. If there is no improvement, that patient is still complaining of all of those same symptoms, then you need to think about increasing that dose. Watch out for your maximum dose, so you can max them out on that dose if you needed to. Again, most of our patients who we put on any of our oral medications, they're likely to have to require some type of ablative therapy, so they'll either end up doing the radioactive iodine or they will end up having surgery. So you can stay on these for a long period of time. I think my friend stayed on it for about 3 years before finally he was just like, okay, this is not working, okay? and ended up doing the iodine. So when you're looking at this, just make sure that you're understanding these are options that you can leave them on for a little while, but does that person want to continue on these meds? Once you hit that maximum dose and it's still not working, then you have to go to that next option, okay? Looking at your remission, you see that that's very low, right? But it can happen. And then our drug of choice, like I said, we like the methimazole because it is better tolerated, but the efficacy of both of them are equal. So this is just saying that there's not one that's better than the other, but there are characteristics that are different between the two medications, but they will both try to get us back to that euthyroid state. So don't think that one is superior. We just like one because it has a better side effect profile, and it's just the one that's most commonly prescribed. But there's nothing wrong with you using PTU if that is what you decided to do. Your methimazole also, hey, look at this. I only have to take it once a day. I like that. Thanks, Doc. I'm also more compliant because I can only have to worry about taking this once a day. And then your methimazole in pregnancy, just make sure that when they're in that first part, our pregnant patients, we have our PTU, P&P, right? Pregnant patient has PTU in that first 16 weeks, and then after that, yes, you can switch them back to their methimazole. Our dosing, just like we were talking about with our levothyroxine and our medications that we have for hypothyroidism, we're going to continue to bring them back in to check those levels. You will see ranges of this. You will see 4 to 6 weeks. Some people may do sooner. It just depends on how symptomatic their patient are. But you're giving that medication a time to get to their steady state, right? To get into that therapeutic window, to see what's going to happen to the thyroid. And remember, these aren't working right away. So you're not going to see the reflective levels that you want to see for quite a long time. Remember that up to 6 months of where I'm going to see that peak effect. But you should start to see where it's declining, okay? And then looking at if you're having that remission occur, then you're going to try to keep them on the medication for a very, very long period of time. So up to 2 years. Sometimes you will see where people go over that. Like I just told you about my situation. You'll have some people where they do go longer than that and they will still have a relapse, okay? So they may go into remission for a little bit and then they're back into that cycle. So, big things from here. What is my mechanism of action? The fact that I have some peripheral conversion as well. What are the 2 drugs that fall into that category? When am I using them when it comes to my pregnancy, right? And then looking at the fact that it's going to take a long time for these to work, I'm not going to see that immediate effect from it. That's our big so what's from this. Looking at my monitoring. Any of my monitoring for any of these drugs, I need to make sure that I'm checking their thyroid levels because am I hitting the right spot? Are we going in the right direction, yes or no? Okay? And the only thing that's going to be able to tell you that are your labs with your T3 and your T4. Also, you're going to look at your LFTs and your CBC because we have a granulocytosis that can occur and potentially jaundice. So that's why we're making sure that we watch out for that. Also, you can see sometimes with jaundice, depending on the patient, where they have like a yellowing of their skin. Sometimes you'll see it in people's eyes as well. So if you see those things happening and they're on one of these thionamides, you should be making sure that you have your labs to back up what you are suspecting is happening. Interactions. So these are very important for you to look at whenever we're talking about if we were giving that radioactive iodine. So let's say that I decided to try to ablate that thyroid in that patient, okay? If I was trying to do an ablation, make sure that you're understanding that you need to discontinue that thionamide before you administer the radioactive iodine. If you don't, it won't allow the thyroid to uptake that iodine, the radioactive iodine. We need that to be uptaken, right, so that I can ablate that tissue. So if my thyroid doesn't take it up because my thionamide is blocking it, it's not going to work. It's not going to be effective, okay? So you have to discontinue your thionamide prior to you administering your radioactive iodine. So they would go off of treatment a couple of days before, so that 3 to 5 days before you would do that procedure. They go into the hospital, they take that one pill, the person watches them take it, and then they leave. and that's it, okay? But they need to make sure that they have stopped this medication at least 3 to 5 days before. When you're looking at your iodides, if somebody has any medication that has those iodides in it, and they're taking it and they're trying to take a thionamide, what you're going to see is that you're going to have more of those stores of the iodine in the thyroid, and then you're going to see even longer onset for your medication to work, for your thionamides to work, okay? So we try to make sure that if we're going to give somebody an iodide, that we're initiating that after we have already had our thionamides on board, so that we don't make those two drugs interact with each other, okay? They would defeat the purpose of each other. Black box warning is kind of what we were talking about already over here with the agranulocytosis right in the liver, the LFTs, while we're looking at our LFTs. So make sure that you're understanding that we can have, I just think about it as serious liver issues, okay? So whether that's liver failure or like an AKI, like liver injury, sorry, not AKI, that's kidding, liver injury, those are big things that we're worried about. You will see that increase that will happen in your LFT, so just make sure you're monitoring that and understanding that you're more likely to see that with your PTU, okay? Your PTU is potentially more dangerous than your methimazole. Jaundice, we talked about that already as a side effect. Your agranulocytosis, we already talked about that. If you see this happening, just like if you see that liver injury, you're going to immediately stop the medication for that patient, okay? You see your leukopenia that you have. This does not mean that it will progress to someone having agranulocytosis. What you can do is monitor it depending on how bad it is. You can also decrease the dose. It doesn't make you immediately say, hey, I have to stop this medication like you're going to do with that agranulocytosis or that liver injury. Looking at your arthralgias and your lupus-like syndrome, again, this is a discontinuation issue that you would have if this adverse effect occurred. So I do want you to remember, like, hey, what am I supposed to do if this adverse effect happened? What am I supposed to do if I had a patient who had hypothyroidism and they started to have those hyperthyroid symptoms? What do I do? That's what we keep talking about when we're looking at these symptoms. And then that rash, again, if you see somebody that develops a rash, we'll just end up giving them some type of antihistamine, Benadryl, something like that, to kind of help them with that rash if they are saying that it's itching. If it's not, most of the time it will resolve. I mean, you don't have to give them anything at all. So, big thing, takeaways from here. What am I monitoring? Make sure that you're going to stop these medications before you give the radioactive iodine, and remember why you're doing that. And then look at your black box warnings, because I can die from these, right? Which is why it's a black box warning. And then look at all of my other things that I have, my jaundice, my granulocytosis, who is my bigger offender, and then what do I do in these situations when I do see this side effect occur. If it's listed there, fair question for us to ask on what you're going to do. This is just a summary of what we already talked about. So you see your drug here, and then you see the fact that you have your comments, okay? We talked about how your methimazole was just more patient-friendly, better side effect profile. Just the only thing that we had to watch out for was if they were in that first trimester. That's why we were using our PTU. But you see that I have a daily administration versus me having to take it 3 times a day. And then my methimazole, I love it. I only love my PTU if I'm pregnant, okay? And then my thyroid stone, which we'll talk about. This, you see that a lot of your patients are gonna take this again for a very long time, what we talked about, so a couple of years. We'll try to take them off. If those symptoms come back again, then it's up to you and the patient. You should be encouraging that they go ahead with the ablation. And then if that doesn't work, then you would say, all right, like, do you want to do surgery? And some of your patients will be very, very severe, and they will want to automatically just do surgery. They don't want to do the meds. So you can also skip using medications altogether when you're treating this. All right, here are our iodides that we have available. So when we're looking at our iodides, these are essentially charged iodine atoms, and they can't be used to make our thyroid hormone, and they also prevent our TPO, our mechanism, preventing our TPO from reuptaking our iodine to create the T3 or the T4. So that's what these are doing. It's a temporary inhibition of those iodine moieties being added to the thyroid hormone. So therefore, I don't have my T3 or my T4 being made. So that's essentially what all of this is saying. They call it the Wolff-Chaikoff block that happens in our patients. So again, just understand that with this, we're just saying, hey, I want to try to decrease the amount of thyroid hormone because I already have too much. Remember, your patient is in that hyperthyroidism state. Reduces your gland's vascularity. Okay, so it's making it to where it's a little bit harder, and it's harder for things to come in and out at that point. This is also something where you can see that if you do decide to do a surgery to actually do the removal, where we will have this medication on board before, because I can make it smaller, and therefore when I do the surgery, I may not have to have such a big incision because the thyroid is so enlarged. So this can help me minimize that scar as well. So this is something that I'm using, building up until I have my patient undergo their surgery. Short-term use, not something that we're keeping them on for a very long period of time. So we talked about like that upwards of 1 to 2 years when we're looking at our thionamides, and here you're seeing where they're probably at 1 to 2 weeks. Okay, so this is just prepping me for that next stage of what I'm going to do. Am I going to do surgery? Am I trying to ablate with the radioactive iodine? What am I doing? This is like that holding drug for us. This is not a long-term solution. This is our Band-Aid. Okay, for how we're going to ultimately fix our problem. Preoperative prep, right? This is what I was telling you about the surgery. So I'm using this prior to because I am shrinking the size. That is a part of the benefit that I'm getting from this medication. When you're looking at all of these other options that you have as far as your use, I just want you to remember what it is doing as far as over here with our mechanism. Looking at the fact that you're using it short term, you're using this prior to surgery, and that you're using this in your patients who could potentially be in a thyroid storm, which is when we're going to talk about it more. So when you see this thyroid storm here, okay? Also, when you see this iodine may exacerbate your hyperthyroidism, think about it in the sense that if you have thyroid hormone that's still floating around and now you're giving it and feeding it more iodine, then I could potentially make it worse. Okay, so that's where you can see that essentially like a paradoxical increase in your thyroid synthesis, your thyroid hormone synthesis. Okay, so first, what you are wanting to do is to put on a thionamide to stop the thyroid hormone from being produced, and then you want to put on an iodide so that you can prevent the release of the thyroid hormone. Okay, so like I want to make my thyroid stop making it, and then I want to say, okay, I now also don't want you to release this. Okay, so thinking about these, they're working together, right? So think about it as like synergistic drugs. The order in which you give them matters, and we'll talk about that when we look at our thyroid storm. Monitoring, same things that we've already talked about. Looking at your adverse effects, the things that are kind of weird here are going to be that, like a lot of things in my mouth, right? Metallic taste, a hypersalivation, and then my swollen, sore gums. Me today, literally. Okay, so thinking about your adverse effects, those are like, think about like mouth things with the iodides, right? And the way that you can think about this too is that they're solutions, and sometimes they're like drops. And most of the time when you have like a drop of something, it usually can sometimes have that metallic taste. Your interactions that you have. So when we're looking at this, we kind of see this already, right? We have our antithyroid or our thionamides that we need to stop giving 3 to 5 days before, and our potassium iodide at least 3 weeks before I can give sodium iodine, okay? So make sure that you're keeping track of your potassium iodide versus your sodium iodine. Your sodium iodine is the one that you're using for the ablation. So anytime you see that I-131, think about that as a radioactive isotope, right? That is used for ablation. Versus when you're talking about your potassium iodide, that is a iodide that you're using for us trying to stop that release of our thyroid hormone, okay? So two separate things. Make sure that you're looking at the difference between the two and being able to correlate the two. So that's why I underlined that one so that you know what the difference is, okay? So 3 to 5 days before, and then if you have that potassium iodide, at least 3 weeks before, you're gonna give the radioactive option. If you do not abide by this, again, the same issue that we talked about previously, you're not gonna have the uptake that you would want with that radioactive iodine, and therefore you're not going to have a successful ablation. They may need to repeat it, or they may think that it didn't work because they didn't discontinue the medication right, and then end up having a surgery that we could have potentially prevented. And then looking at our lithium. Lithium interacts with everything, okay? And this is one of those drugs that I told you, hey, put it in the interaction checker, because it has a lot of them. So making sure that you're understanding that your lithium can stop your thyroid hormone from being released, and so therefore you can see that it can essentially decrease your thyroid function is what's happening with your lithium. Okay, so our interactions are important in this slide deck more so than our others that we typically look at. So that's why y'all hear me talking about it more. In the order in which we give these medications matter a lot because of these interactions that we have. Here are our drugs listed here of what we have as our iodides. So I have my potassium iodide and iodine, which is called Lugol solution. We'll see this sometimes used as an antiseptic to prep patients sometimes. And then you have your SSKI, or your saturated sodium potassium iodide, that can come in a solution or a tablet form also. You see they're dosed quite frequently. Good medications, we'll talk about these whenever we're looking at our thyroid storm. So when you are looking at these are called iodides. This one has iodine in it, but iodide means that it has 2 iodine moieties attached to it. Here you see something that's kind of neat and unique to us. So if there is a nuclear accident, what we could do is try to give this one of our iodides to prevent the uptake, essentially, of our the radioactive isotope. We can prevent the uptake of that. So this should help you remember why we have to stop it at least that 3 weeks before we're giving our radioactive iodine, or our I-131, right? It would block that medication from working. So the same thing if there was like a nuclear accident and you were like, oh, let me go and get one of my iodides, or if it was a nuclear attack. Let me go and get one of my iodides, and I give this medication to the patient, and essentially it would try to help my thyroid not uptake, okay, that radioactive iodine that I was exposed to, okay? Okay, this is the one that I was telling you to make sure that you're paying attention to. Your SSKI, or your Lugol, with your radioactive sodium iodine, or your I-131. So with this is going to be administered orally. They'll go into the hospital, they'll take the capsule. We also have a solution for them, but most of the time they just swallow a capsule, and then the thyroid will rapidly incorporate it, and then you'll have that beta emission occur, and that's where we have the ablation happen in that local thyroid tissue. Now, sometimes it will kill all of it, sometimes it may kill some of it. That's whenever we'll get those levels. Sometimes they'll bring you back in like a week or 2 after, and they'll get some of those levels and try to see like, hey, what's going on? But you're not going to see those full effects until, again, that 6-month period. So we're seeing that again, up to 6 months that it can take. Looking at your dosing, most of the time you'll have that one dose. It's going to be, the pharmacy makes these medications for them. It'll be a nuclear pharmacist. So we have nuclear pharmacists who make meds that we use in the hospital for like imaging and things like that. So a completely separate pharmacy. So they make those medications for the patient based off of all of these different parameters. Send it back, they take it, and then a lot of your patients are going to be okay. When I say okay, they'll be hypothyroid at that point. And then some of your patients, it may not touch them, and they'll need a second dose. So that's where you see that 20% at. We wait a while before we do that because we want to see what that full effect is. So that's why you see that second dose isn't given up until 6 to 12 months after the fact, because I want to see what their peak is before I give them another dose. And then your monitoring, again, Same thing that we've been monitoring, same 4 to 6 weeks that we've been talking about already. With this pregnancy test, okay, because we are exposing them to this radioactive iodine, you need to make sure that they are not pregnant. Some people will allow you to do the 48 hours and some will do it the day of, because I don't know what you did in the last 48 hours. So I want to make sure the day of. That is up to you. What you're supposed to do, it says 48. Anytime I see stuff that says 48 or says a week before or any of that, I'm like, nope, the day of. You come in, I want my license and I love it, okay? So that's just a personal thing, but 48 hours is your window that you have. When we come back, we'll keep talking about this. Let's take a break. Remember to make sure that you're not mixing up your iodides, right? Making sure that you're separating it, looking at our interactions and what's going on. When do I use it versus when do I not use it? Adverse effects. So like we were talking about with most of our meds for hyperthyroidism, I can overcorrect and cause hypothyroidism. That is the biggest thing. I have ablated their thyroid. So now their source of thyroid hormone is gone, right? So this makes sense as to why I can see this hypothyroidism. Very rarely will you see that it ablated enough to where it's just euthyroid and they're not on medication. But that can happen where the iodine didn't take up everywhere, and so they can still have some thyroid hormone being produced by that thyroid. Looking at your pain, just understand that like things can get worse in some of your patients. You can also see where their thyroid eye disease or their TED can get worse for a little while. But again, just understanding that there are medications. We'll use our prednisone prior to try to decrease the amount of pain and discomfort that someone may feel when they undergo this procedure. Looking at your permanent hypothyroidism occurring in about 80% of your patients, okay? When you see that, that is a pretty decent success rate, right? So your chance of relapse is very low. But I'm still having to take something, right? Permanent hypothyroidism, I have to now take my levothyroxine, okay? So that is where most of your patients land. The other 20% is going to be your people who hit on that euthyroid or your people who it didn't work, okay? And they're going to end up having to have surgery. Don't use it in our pregnant patients. This looks familiar, we saw this already. And then your patients who have severe ophthalmosis, right? So they have that very severe eye disease. Just make sure that you're watching out for your patients with that. Whether or not this is an absolute contraindication is very controversial because some providers, they don't care and they will still do this. And other providers think that because it may worsen it, they don't do it. But now that we have a medication for it, that's why you kind of see people going back and forth with this on like, well, if it does happen, then I have a medication that I can use to treat it. So some people aren't as worried. So just look out for that as a caution more so than like a contraindication, because they're back and forth about it. Interactions, you've seen these, we're seeing them again. Make sure that you're stopping your thionamide 3 to 5 days prior. You can restart them after treatment because remember, this is going to take a while for it to work, up to 6 months for this to work. Discontinuing your potassium iodide 3 weeks before. We saw this already on those other slides as well. And then your lithium, okay? Lithium is showing up in a lot of these medications, prolonging the retention of that radioactive iodine, which we don't want to happen, okay? Overkill, essentially. Oh, our beta blockers. Okay, so we already know about our beta blockers. Making sure that you're using this as symptom control, okay? This is essentially looking at us saying, hey, my patient is symptomatic because they have that hyperthyroid going on, and so they're activated, right? Tachycardia, sweating, weight loss, all of those things that are happening. You'll also see that when you're specifically looking at your propranolol, which is the one that we typically like to use in our thyroid storm, or our nadolol, you can see where you have some blockage of that peripheral conversion as well, of your T4 to T3, okay? So that's an added benefit that we're seeing, again, with that peripheral decrease in our thyroid hormone. Making sure that you're understanding that you can leave your patient on this while they're taking their medications for hyperthyroidism if they're still having those symptoms occur. And then over time, especially if they've been on for a longer period of time, we need to taper them off of these medications. Can't just abruptly stop them. Looking at our adverse effects, things that we've already seen before, so our hypertension, bradycardia, all of those things. Your caution, again, your patients who have asthma, the withdrawal, your diabetes. So all the things that we've already discussed when we're looking at our beta blockers, but make sure that you're looking at the fact that it says are non-selective. So remember, these were our O through Z. I think I said N. Maybe, no, it was N through Z. And then looking at your drug interactions that you have, again, if you're using it with your beta agonists or your non-DHPs, you can see those additive effects that could potentially occur, or the antagonistic effect if we're talking about a beta-2 agonist. Here are our different options that we have available. Typically, we're using our first two, which are going to be your propranolol and your nadolol that we have, but we can also see sometimes where we're looking at our metoprolol, and in very, very severe situations, we have, remember this was our only one that was IV. So if we, for some reason, needed an IV formulation, you have your esmolol that is here as well. So I want you to look at your drugs that we have, look at our comments, and then remembering that your propranolol and your nadolol, so those first two, are the ones that you see where you can have that decrease in your peripheral conversion of your T4 to your T3. Most of the time, we're going to be using our propranolol when we're talking about like thyroid storms and things like that. Those are the big things that we're looking at here. Your thyrotoxicosis, again, remember we had, this was saying, hey, I have too much thyroid hormone, I had my amiodarone induced, and then I have my thyroid storm, which is a form of thyrotoxicosis. I have too much thyroid floating around. That's all I need you to know from here, is that your thyroid storm is considered a thyrotoxicosis, okay? These are your elevated levels, and that one of our drugs that can cause this could also be our amiodarone. So this is us now looking at our thyroid storm and how do I treat my patient who presents with a thyroid storm. So when we were talking about hypothyroidism, we had our life-threatening myxedema coma. Here, we're looking at our hyperthyroidism, which could potentially also be life-threatening to some of our patients. So you will, when this happens, it's kind of the same way like what we call a code for stroke, anything else. Sometimes it depends on how fast your patient is decompensating. You will have several people around and several of these things are happening around the same time. What is very important to happen in order is what you see numbered as 1 and 2. So your anti-thyroid medication, which is going to stop that new thyroid hormone from being produced, has to be given an hour before you block that thyroid hormone with one of your iodides, like your iodine solution, your Lugols or your SSKI, okay? So this is the only thing that is in an order, okay? It has to be done in this order, because if it doesn't, then you're going to stop that uptake that we need to occur. When you're looking at your anti-adrenergic therapy or our beta blocker, again, that's the symptom that we're looking at, but I can also potentially get that minor decrease if I pick my propranolol or my nadolol in my conversion of my T4 to my T3, okay? So that is where you're seeing these medications come into play. This order matters. These medications, doesn't matter if you give it to them or not. You may not have to give a beta blocker. Maybe they're somehow coming into your clinic or into the emergency department and they don't have these symptoms, which most of your patients are going to have symptoms. These levels are very high when they have a thyroid storm. Think about it as a storm, right? Like everything it's hailing for this person. So this, you will hear some people say like, oh, give that first. It doesn't really matter if you're giving this first, because if I'm still having thyroid produced, I'm chasing something, right? So I want to stop that hormone, and I can at the same time be worrying about giving them that beta blocker to help their symptoms at that very moment. So that takes care of those. Looking at our Tylenol, this is just, or our acetaminophen, this is just helping if they have a fever, trying to, cool your patient down, relax their blood pressure. That's all that's on there for. You have your corticosteroid therapy that you can give. This will also kind of help with the T4 to T3 conversion peripherally, a little benefit from that as well. You see your bile acid sequestrant. So remember we talked about these and how they interfere with the uptake of a lot of our drugs. So this, if we're using it to our benefit, right? I have too much hormone, so I want to use my BAS so that I can start to excrete that instead of my body recycling that thyroid hormone and continuing to incorporate it, okay? So now I'm using that adverse effect for my benefit because I have this toxic level of thyroid hormone. And then eventually, depending on where your patient is, how bad it is, if you can get it under control, what they need to absolutely stop this from happening again would be that ablation or potentially the surgery. So this is that same exact thing, but with the actual drugs so that you can see them listed here in a different kind of format, okay? So just like we typically talk about with our beta blockers, if somebody can't take a beta blocker, you see that we can use our non-GHP when we have our DILT listed here in this option, but you have to know that there's a contraindication to it. But this is just now giving you the actual drug names instead of on this slide, it was just giving you the drug class and the explanation. So same exact slide, but instead of you having to go back and forth, we have it in here so that you can see it this way and know what your treatment regimen looks like. So some of these meds may be put on there. Most of them we do. The only one that matters for your order is going to be your PTU and your SSKI or whichever iodide you choose to give, okay? That's the only one that matters about your order. Yes.
So just so to confirm that, so you're giving them, like, let's say theoretically everything else and the first step of the PKU and then moving on to the second step, like, since the order doesn't matter for the rest of it?
You could. So most of the time what's going to happen is 1 and 2 typically happen first. There have been situations where some people have the belief of giving your propranolol, so that's why I have it up there, but just without a number. Because some people will be like, oh my gosh, my person's heart is going crazy, and they're like, I need to do something now, and they'll say, you have to do that first. You don't necessarily have to do that first. The only thing that you have to do in an order is your 1 and your 2.
Right.
So, and realistically, all of these things are happening at once. You could give any of these drugs with number 1 and you're waiting an hour before you get 2.
Sweet.
So you could just be, everybody is piling stuff on, just make sure that the iodine isn't being given at that point. You have to wait the hour and then you can use that one.
Makes sense.
Alright? And then just a little case that we have for here. So our patient has a thyroid storm. Which treatment would they benefit from? This is just giving you a whole bunch of extra stuff that you don't need. But if they have a thyroid storm, what do I need to give my patient?
You?
So I can give them this. I can also potentially give them some Tylenol, but they're gonna benefit the most from this. This is gonna make them worse, right? If I give them Synthroid, because I'm adding now on more thyroid hormone that they don't need. I said that this was helping me, right? But is this actually, like, it's helping me with my fever, it's helping me a little bit with my blood pressure, but that's not my main concern. My big benefit and what I'm worried about and what I'm trying to benefit the most from is that hormone therapy, right? Decreasing the level of hormone. So that's why you have your PTU here. I can end up in this situation where I have my radioactive iodine, okay? But I need to fix it now. This takes a long time for this to work, all right? Okay, let's pull up our next slide deck and get some into that so where we can finish that tomorrow. And then we'll have diabetes next week. So with the diabetes lecture, that is the one that we're going to interact with in class. It is supposed to be fun for us so that we can all talk. Y'all have great personalities and great ideas. and we're going to use them, okay? I'll give you prompts for everything, and so you'll be broken up into 8 groups. You'll have prompts that'll say like, hey, this is what you need to make sure that you're looking at when you're going over these slides. So y'all will all have like, I don't know, I can't remember how many slides it is. I'm also going through and deleting a lot of slides, so I'm going to post that probably, I'll try today. If I don't, we'll have it on Monday whenever or not Monday, am I here on Monday? Tuesday. So it will be up by then. So just letting y'all know what's going on. That will be the last one that we have after this one, and that'll be the one that we'll be teaching. Yes.
I just had a quick question for the hypothyroidism stuff.
Yes.
Just for like knowing Graves' disease and like hypothyroidism, do you just know the concept like we're not being tested on?
No, not testing you on those things. I will tell you that they have those things. I just want you to remember which classification, hypo versus hyper, so you can remember your drugs that you have when you're treating hypo and hyper. Okay? Because if I said Graves, I'm not going to tell you what it's attached to. If I said thyroid storm, I'm not telling you that they're hyperthyroid. Right? So that just knowing that which one's going into which class. If I tell you about a coma, where does that belong? Okay, so hypothalamic and our pituitary medications. We have a lot of different meds that we're going to talk about here. I will try to like tune you into some of the bigger concepts that I want you to look at. There's a lot of words on some of these slides, so just listen to my voice as I guide you through some of those words, okay? Make sure we are highlighting, make sure we are bolding as well. Some of this I have already bolded for you, but if there's anything else, just listen to me, okay, so that you don't get too overwhelmed. Here are ELOs listed here, same things that we already always talk about, bless you. So when we're looking at this, again, we're talking about the hypothalamus, we talk about like all of these different hormones. Depending on what hormone is secreted, we have all of these different cascades, and we have negative feedback loops that are happening where your body is like, hold up, I'm good, I got enough, stop. Okay, so it goes back and it'll shut things off either at the hypothalamus, or it can go to your anterior pituitary, posterior pituitary, and say, I'm good, I don't need anymore, right? So we're going to look at a lot of these drugs, which ones fall into which categories. We're going to look at some of the feedback loops that we have as well. So just like we saw with our thyroid, our anterior pituitary is where we're going to see our thyroid stimulating hormone being released from, right? So we talked about this. We said, hey, our metabolism, our growth, we'll get into some reproductive things as well. This is where we start to see those things come into effect. This is where we're starting to trigger hormones, okay, to be released or to stop and suppress those hormones. So hypothalamus, you're going to get that input, and then we're going to release hormones either from our anterior or our posterior pituitary. And then when you have your posterior pituitary gland, you have an anterior and then that posterior lobe of that pituitary gland. Okay, so we're going to talk about drugs that affect each of these areas. This is just a picture letting you know, like, okay, what part of my pituitary am I looking at, and where are these signals coming from? So your hypothalamus is going to get signaled, and then you see your anterior pituitary are all of these things that are over here to your left, and then you'll have where they're either going to be stimulated or they're going to be inhibited by hormones that are secreted from the hypothalamus. So this is like the brain, right? Like this is triggering how everything else is going to function. And then I hit my anterior pituitary, and then I can have where some of these things will send back up a signal either to my anterior pituitary, or they will send back up a signal to my hypothalamus and say, I don't need any more, stop stimulating me down here, okay? So that's my negative feedback system. And then you can see that these are your target organs that you have here when we're talking about our anterior pituitary, and they're mostly dealing with like growth, metabolism, that reproduction that we were talking about. So when we see anterior pituitary, that's what you're thinking about: growth, metabolism, reproductive system. When you look on your right hand side, this is your posterior pituitary that you have. So same thing, hypothalamus sends that signal, posterior pituitary is going to then stimulate those target cells or target organs. And then they will have where you have your oxytocin listed here, and then we have our ADH, which we talked about, that anti-diuretic hormone, which we talked about previously this semester. So we're going to talk about that a little bit more. So when that blood volume is low, our ADH is supposed to try to get things stimulated for us, okay? This is an important concept because this is looking at our HPA axis and trying to say, all right, how does this function? How is my body regulating these hormones? How does my hypothalamus know when to secrete and when to stop secreting? So this is that negative feedback system that I was telling you about. So you have your hypothalamus, which secretes your corticotropin releasing hormone. And then that then stimulates your anterior pituitary to release your adrenocorticoid hormone, or your ACTH, which then triggers your adrenal cortex, and then you will see produce your cortisol. Okay, so that the red in factor is your cortisol. With this, when I get enough cortisol, and it starts to build up, I have that negative feedback where it will go back and it will either hit that anterior pituitary or my hypothalamus, and your negative signs here are saying stop, right? I don't need any more cortisol to go out in my body and carry on any action, because that's my end product that I have here. So when I have enough, I go back to my anterior pituitary, or I will go back to my hypothalamus and I will shut everything down. So, when we're looking at these different hormones that you have, these names are a little confusing, so I tried to have them in this chart so that we can see everything kind of all on one table. So, when you're looking at your hypothalamic hormones, these are the things that could be released from the hypothalamus that have a functional chemical. So, these are all different types of functional chemicals that are coming from the hypothalamus. And based on the hormones that are released, the pituitary will then release one or several of their hormones. So it's coming from here, and then it's going to hit either my anterior or my posterior. Okay? So these are all hormones that can be released. This triggers what is happening on this side. Okay? So my left is triggering what's happening on my right. All right? When you look at the anterior pituitary, you see that we have several different things that we can have released, several different hormones that are released. And then when we look at our posterior pituitary, you see that I only have my ADH, or I have my oxytocin that's going to be here. And these kind of go together with your vasopressin as well. Okay, so this is what we saw on this slide, but now in words with all of our different hormones. So you have your growth hormone releasing hormone, your growth hormone inhibiting hormone, and I try to remember this by, like, when you're inhibiting something, you're stopping it, so statin, like it's stopping it, and you'll see in the brand name, you see somatostatin. Your thyrotropin releasing hormone, corticotropin releasing hormone, gonadotropin releasing hormone, which you'll sometimes see, and when we go over the slides, you'll see it with the luteinizing hormone releasing hormone. Prolactin inhibiting hormone, this is one of those that is kind of a little bit different, but this one you'll see where we're dealing with dopamine, which is not what you're expecting to see when you're talking about prolactin. We'll get into that one a little bit. And then our anterior pituitary hormones, you see that I have my growth hormone. This one is not the same as this one, my growth hormone inhibiting hormone. This is somatostatin, this is somatotropin. Okay, so don't get these two things mixed up, two different things coming from two different areas. You have your thyrotropin, thyroid stimulating hormone, adrenocorticotropic hormone, follicle stimulating hormone, luteinizing hormone, prolactin. Remember we were talking about different sex hormones and like fertility and all that stuff. That's where we're going to see a lot of these medications coming from and what they're trying to mimic and stimulate. And then our posterior we talked about. So what we're going to look at first is going to be our hypothalamic hormones that we have. So when we're looking at this, think about this as our clinical uses that we have, and when can we use them, what are we using them for. Instead of the hormone signals that would naturally come from the hypothalamus in some situations, we now have these drugs that are trying to either mimic or replace essentially what our body is not doing anymore. So this can allow us to synthetically essentially modulate or mimic what my body would have been doing. So you see you have replacement therapy in a situation where you have a deficiency, and then you see that you have antagonistic properties in situations where you have too much, okay? So an excess production. So I have an antagonist because I want to stop it, whereas if I have replacement therapy or if there's some type of deficiency, then that's when we'll typically see our agonist being used in those situations, right? Because I'm trying to mimic something. You'll also see where some of these, they're not anything that you would prescribe. You would use them in clinic to try to diagnose a patient with something, but not send them home with that medication. So we'll try to say like, hey, I want to see if this person has adrenal insufficiency. What can I do? What kind of medication can I give them and see what their response is? Depending on what their response is, I can diagnose them with different types of conditions. We'll talk about that a little bit also. Here are all of our hormones, again, that we were looking at, so we're going to start kind of going through these. Our GHRH, this is not something that you'll typically see used anymore. Same thing when we're talking about our thyroid releasing hormone. Just understand that we're using this as an assessment of our thyroid function. I'm not going to ask y'all about this. Not even on something that we use anymore for the most part. So just for your information, if you see your that thyroid releasing hormone assessment is not approved by the FDA, but we have sometimes where people do some real interesting things, and we have research that does go on in some places. So again, just FYI that, just want you to know that it does exist though. Okay, so looking at these, you have your GnRH and you have your LHRH. When we're looking at this, again, we're in our hypothalamic section, right? So these are things that are going to be secreted by the hypothalamus. We have different ways that they can be secreted from the hypothalamus, and so this is the big part of what you're seeing here. So again, when you're looking at where these are working, your FSH, anterior pituitary, LH, anterior pituitary, right? So I have these hormones that are being released, and then they're going to go and target my anterior pituitary, but I have different functions of each of these hormones. So when I'm looking at my FSH, this is talking about my follicle development, okay? We see this when we're looking at, when we talk about the menstrual cycle, and you see that chart that we always have with the lining, and you look at the different levels and how this is one of those things that is a part of that quite a bit. So this is dealing with your follicle development. We talk about this a lot, again, in that menstrual cycle. You're also going to see LH involved in that as well. But for our women, follicle development. When you're looking at our men, same thing. Think about like the things that we use to make babies. I need my follicles and I need sperm, okay? So you have your spermatogenesis that is also going to be here when we're talking about our males. This is what is stimulated FSH by FSH, okay? That is what you're seeing happening as a result of FSH. Then you have your LH. When we're talking about this in our women, you see that you have that androgen production. So again, dealing with our ovaries, but more of like I try to think about like steroids more so in this situation. So we have our androgens in our women, and then you have in your men, you have the testosterone syndrome, or testosterone synthesis syndrome. Okay, so that's why I say like our sex steroids, androgen, testosterone. This is dealing with how you are going to administer it. So based on how it's administered to the patient, you get different responses. Okay, so if I talk about a sustained or non-pulsatile administration, that is going to suppress. So put your S with your S, right? My sustained SU is going to suppress. So then I'm going to decrease the development of those follicles. I'm going to decrease the development of that sperm. Okay, so therefore I'm going to have less levels of my LH and my FSH if I'm giving it in a way that is sustained. Okay, so sustained meaning I'm not giving it in a pulsatile manner, so that's why you see sustained non-pulsatile administration. I will see suppression. Okay, So when you think about that, hypogonadism, down, right? Suppression, I'm decreasing everything. When I give this in a pulsatile manner, okay, so I'm pulse dosing you, I'm not keeping it on for, like you're not taking this every day, you're taking this on certain days. I'm giving it to you in a pulsatile manner. When I give it to you in a pulsatile manner, I am stimulating you, right? Just think about somebody continuing to randomly poke you, and you're like, oh my gosh, stop, right? Pulsatile, I'm stimulating you. I'm stimulating your nerves. So therefore, in this situation, you'll see where you have that LH and that FSH that's going to be released, and therefore, you should start to see the increase in those effects, right? So I can start to see increase in my androgen and my testosterone. You'll see that we'll use these in different time frames. We're going to talk about these a little bit more, but this is a big idea that you're going to see come up, and I need you to make sure that you are remembering this idea. Okay? Because you might see it again. Alright. Looking at our GnRH and our LHRH again, you have different now analogs. So that was typically like the hormone that we have in our body. This is now my medication that I have made. Okay? So again, I can decide on how I'm going to administer that medication. I can give it in the pulsatile, or I can give it in the non-pulsatile, right? So whenever I'm doing my sustained non-pulsatile, I am stopping stuff. I am suppressing stuff, okay? So therefore, you're going to see a suppression of those sex hormones that we need. So my follicles and my sperm levels have now gone down because of this. Whereas with my pulsatile, again, I'm stimulating, and therefore I can see an increase now in my androgen and my testosterone, okay? Because I have now an increase in my LH and my FSH. So, adverse effects that you can see whenever you're giving your medications, with giving some of these medications, is that you can see a disease flare occur within the first week of us trying to start our medication. So with this, what that looks like is, just think about this as like it's involving your sex hormones. So think about like somebody who's going through menopause, who is just not feeling fantastic, right? They're getting older. That's how I remember these. So like the bone pain, the hot flashes, the decreased libido, like all of these things are all involving that sex hormone that we are seeing being fluctuated or controlled by us administering these meds, whether I'm increasing or decreasing that. Also, a lot of these are injectable, so you're going to have that injection site pain, redness at that site, increased risk of infection, like we always say, right, because I broke that barrier. So just make sure that when you're looking at this, again, understanding the difference between the two, and then looking at the potential of a flare that you can have. So when we're typically talking about our flare, for the most part, you'll see that whenever I'm doing my pulsatile. Okay, this usually is associated with that flare. Your pulsatile is the one that's usually associated with the flare. Because remember, now I'm pushing it out. I'm stimulating it with my pulsatile. So, my drugs that I have available to me. You see that we have several different ones. There are also several different formulations of these medications that are available. So I have my Goserelin. I have this as an implant. I have a long-acting one, and I have one that is going to be a monthly one, okay, versus every 3 months. You have your Leuprolide. There's several different formulations, again, of your Leuprolide. So you have different brands, and based on that brand name that is available, you see that you have several different ways in which you would be administering it, daily, monthly, what have you, implant versus a sub-Q injection, several different ways that you can give it. So when we're looking at this, what I want you to look at is the fact that these have different formulations, and then how with your Narcolepsine, how I underlined that one is a nasal spray. This will also come into effect a little bit when we talk about some of those things. So just remember that we have several different formulations: implant, sub-Q, usually how you're going to see some of these. And then if I give you a depot of something, remember anytime we talk about depot, those last longer, so therefore you can see where I'm not having to inject myself as often. My Nerfalin goes at my nose. Inhalation in my nose, okay, nasal spray. And then you have your Histamine and then your triptorelin that you have available. So we haven't seen a lot of drugs that we talk about that are implants. This is kind of one of those first ones where you're seeing like they're like little, it's kind of like a matchbox, I don't know if anybody uses matches anymore, but like the wooden matches that we used to have that are very, very thin, that's the implant that we're putting in to, that's like the size of what it kind of looks like for our patients. All right, these are those same drugs that we talked about, but now we're looking at when do we use these medications? When am I going to give my patients these drugs to help with these different disease states that they have? So you need to remember where they go, because each one of these fall in a different clinical indication. They're not all like, it's not a free-for-all, okay? So when we're looking at prostate cancer, you have your leuprolide and your groserelin that are options. And then the dosing is very important here. Because remember we said if I'm doing sustained versus if I'm doing pulsatile, I'm getting a different result, right? So your dosing also matters, and that's why I slowed down when we're talking about that dosing, because that then goes into play with how you're going to administer these meds, because I may want a different result, right? So when I did my sustained, what was I doing with my sustained? Was I suppressing or was I stimulating stuff? Suppressing. So does that make sense why I'm using that in a sustained manner in somebody who has cancer? Yes. Right? I have all of this growth. I'm trying to slow everything down for this person. So I'm giving it in a sustained manner. Okay? When you look at your ovarian suppression, if somebody there's several different types of different disease states that people can have to where we may want to slow things down. So you see your groserelin is used again, you have your leuprolide again. My Naphthalin, how is this one given? Nasally, okay? And then you see that these are also, again, sustained doses that we have. So those are just some different examples of when you can see that we will be giving our patients those medications, right? Your central precocious puberty, this is one of the ones that I try to help you remember by saying, right, if I'm a kid, I don't want an implant. I don't want to have to inject myself subcutaneous either. So if you have Nerfalin, I can just take an inhalation in my nose. This is patient friendly for that disease that I'm trying to treat in that child, okay? So this is essentially, they're hitting puberty at a very early age, and you want to stop it. You want to slow that down. So that's again why we're giving it in that continuous or that sustained dose, because I want to stop their puberty. When you withdraw this medication, they will then go back through that, that's when their puberty will start, okay? So again, the way that we administer it matters. So make sure that you're remembering how you administer it, because that will help you remember your clinical uses when you're using these meds. Looking at your endogenous puberty, so if you have someone who is undergoing or trying to undergo a gender reassignment or any of that, you can see that we can use these medications for that as well, and that's any of these medications. And then your ART, or your assisted reproductive technology, so when we're talking about things like IVF or in vitro fertilization, or you're trying to retrieve eggs and do ovulation induction, you can see where we'll use these medications, and they're on certain days that we're using them to try to stimulate them, right? So it's not something most of the time that our patients are using all the time. So we're trying to stimulate or trigger them in that agonistic way, okay? So when you're looking at this, big thing that I wanted you to remember is what drugs fall into this class, and then look at the fact that we have sub-Q options, we have implant options, and we have the one that I can use in my nares, my Naphthalin for my nares. And then when I get over here, I'm saying, hey, here are my clinical uses for these medications, and making sure that we're paying attention to how we're giving them, okay? And then when you look at this also, Remembering that your puberty, your early puberty, you have your Nephilim, which is patient-friendly for your kid. All right. This is just looking at what's happening when we're talking about our prostate cancer and how we're giving the medication. Don't need you to go into this that much. Just understand if you want more detail about how they were working outside of what we just talked about. This is literally going into it step by step and letting you see how we're giving the medication and the fact that our LHRH is being released in that pulsatile manner to the anterior pituitary, and then you see your LH and your FSH being released, and then it goes to that target. Your LH is going to go to the target, which is the testes, and then you'll see the testosterone being secreted, and then therefore we can see that, hey, this is kind of what's driving that cancer in that patient and causing those prostate cells to continue to grow. All right, this is looking at our agonists versus our antagonists. So these are the definitions that I was talking to you guys about before. And when we talk about an agonist, remember that it's trying to mimic what our body normally has. So we said, hey, I want to make a drug that does what my body already does. Most of the time when we make our drugs, our agonists or our analogs, they last for a longer period of time than what our endogenous hormones will do. Okay, so we just said, I'm going to be a little bit smarter. Let me prevent them from being degraded quickly until I have my medication. Your antagonists, remember your antagonists are going against, okay? So it's trying to suppress something or do the opposite of. So when we're looking at this, you have your antagonists. Most of the time we're talking about our antagonists. We're going to be talking about like things like our prostate cancer, if they're in like that more of a severe disease state. You also see that you'll have a quicker onset when we're looking at some of our antagonists and less of a surge, so you don't have such a huge flare, like we were talking about before with that adverse effect where I said, oh, the flare that happens in the first week, you typically are going to see that in your agonists because your agonists are the ones that are doing the stimulation, right? So that's why you see that flare with the hot flashes, the decreased libido, all of those things, that bone pain. So when you're looking at this, just kind of correlate these things and understand that you'll have different symptoms and adverse effects, I should say. You'll have different adverse effects depending on if you're giving an agonist versus if you're giving an antagonist. If I give my agonist, I should be expecting to see a flare. If I give an antagonist, I'm not expecting to see a flare. Okay? And that is just by way of the mechanism because I am stimulating, I am going to see that flare because I'm stimulating with my agonist. What else I want you to know? That's the big idea from here, okay? Seeing a flare versus not seeing a flare. What are my agonists doing versus my antagonists, okay? Your antagonists do work a lot quicker. You'll see that immediate suppression in those hormones that are happening, and that's what I already have underlined for you. Y'all look over it. We can stop. Oh yeah, this last slide, and then we'll stop at anterior to anterior. Y'all do y'all like this. Remember, we can't have the same energy. If I'm down, you have to be up. And if you're up, then I can be up too. That'll be a fun class. We haven't gotten there yet. Okay. When we're looking at our antagonists, don't make me laugh, Kyle. I don't know why I tried to make a joke today. Bad idea. When you're looking at your antagonist, so remember when we said our antagonist, does it take a long time to work with my antagonist or is it more immediate?
Immediate.
Immediate. Am I seeing a flare when I'm talking about my antagonist or no flare?
No flare.
No flare. So this is essentially what we already talked about. I'm immediately blocking those same hormones that I've been talking about to you this whole time, my FSH and my LH. And I'm immediately doing that. I don't see my flare because I'm talking about an antagonist. Turning off my GnRH receptor, and therefore I am preventing that surge from happening. I am preventing that flare from happening. When you're looking at your agents that you have available, this is now breaking those down for you so you can see what are my agents that I have that will help me have these antagonistic properties. So when you're looking at this, you see that I can use this for my women undergoing my ovarian hyperstimulation procedure. So this is like my ART that we were just talking about, right? So my assisted reproductive technology. I'm using my medications to help with that. I have my Gamalex and my Cetrorelix. These are both sub-Q medications that can be used. women are using these medications. For my men who have my prostate cancer, I have my Degralex. You see that these are sub-Q options, so these are injections that that patient would be given. They can do that themselves at home. They don't have to come into you for this. So these are things that can be prescribed to your patient. Adverse effects, big things that you're going to hear is that that injection site reaction, so the redness, the pain, increased risk of infection, bruising. People don't love them. They don't feel great. All right? We will finish this tomorrow.